Good afternoon, everyone. Calling a meeting to order for HHS Health and Human Services briefings readout. We have 4 of them today. We have State Archives. We have Maryland Department of Health, Public Health Administration. We have MDH Regulatory Commissions, and we also have Department of Human Services Administration. At this time, we're going to start with our first, and we're going to bring up our budget analyst, Jacob Polikoff, for State Archives.
Thank you, Mr. Chair. State Archives, being Maryland's central depository for government records of permanent value, retains information from all 3 branches of government and is one of the largest state archival organizations in the nation. The fiscal 2025 budget, as we'll see in the middle of page 1, decreases by $167,982, or about 1.6%, to $10.6 million. On page 2, we have an overview of the agency's spending for fiscal 2025. Again, that's Exhibit 1 in the middle of page 2. The majority of the State Archives budget, 70%, is allocated towards personnel spending, with rent expenses, contractual services, and contractual employees accounting for a significant part of the remainder. On page 3, we have the proposed budget change for the archives. As I mentioned, it's a decrease of 1.6% from last year. Couple of things that I'd like to note are an increase for salary increases and associated fringe benefits, including the fiscal 2024 COLA and increments, along with an increase in funding for their the Department of Information Technology Services allocation, and a removal of funding for a 2-year computer server replacement process, which has been completed. On page 4, we have personnel data for the State Archives showing that they have no new regular positions this year, 1 additional contractual FTE. As of December 31st, they had 1 vacant position, which was just below their budgeted turnover rate. On page 5, we'll discuss the public programs offered by the State Archives, which increased in fiscal 2023. The State Archives hosts a number of programs throughout the year for the general public. Programs include a variety of tours, lectures, and other offerings. Exhibit 3 in the middle of page 5 shows the number of public programs which have been offered each year since fiscal 2019. Of the 123 programs offered in fiscal 23, 79 were in person, while the remaining 44 were virtual. Programs include a variety of forms, including field trips from schools, workshops, lectures, and tours of the archives. The State Archives does not track the number of attendees at every type of event, but it reports that 13 of the virtual programs hosted in a partnership garnered 4,117 attendees in total. In order to ensure the programming is effectively reaching the widest possible audiences, the State Archives should collect more detailed data regarding attendance at different types of in-person and virtual events. As an example, attendance data comparing in-person lectures and virtual lectures on similar subject matters could assist the State Archives in making plans for future events if a trend can be identified showing that certain subjects are likely to draw a higher number of attendees online, or that certain groups of attendees are more likely to attend an in-person event. Evaluating data to maximize attendance at all events may assist the agency in reaching as many Marylanders as possible with their events and other programming. Therefore, the State Archives should work with the Department of Budget and Management to include detailed data in their managing for results submission. Data should include the different types of events held by the State Archives and attendance at virtual and in-person programs hosted by the State Archives. On page 6, we'll discuss the growth of the physical and electronic collections, which continued in fiscal 2023. The State Archives makes determinations throughout the year on the retention of certain local and state records of permanent value. These items include government and citizen records, artwork, historical papers, and others. The agency collects and maintains these records and other items on behalf of the state. Since fiscal 2019, the number of items in the physical and electronic collections has continued to grow each year. The items currently held by the State Archives include more than 400,000 cubic feet of materials and over 178,000 gigabytes of electronic data. We can see more in Exhibit 4 at the bottom of page 6, which shows information on the growth of the physical and electronic collections. The database records managed by the State Archives number in the millions, with growth occurring in most years. Fiscal 2020 saw the implementation of a new database system, which resulted in the removal of 4.6 million records. The decrease seen in that year was temporary, as we'll see in Exhibit 5 in the middle of page 7. Numbers have since rebounded, beginning with fiscal 2021 and in subsequent years. The State Archives is dependent upon a network of computers and other equipment to scan, create, maintain, and make available the millions of database records in their care. In fiscal 23 through 2024, the State Archives received approximately $950,000 for a replacement computer server. The fiscal 25 allowance includes funding for a replacement data storage device and new workstations in the Baltimore and Annapolis facilities. The State Archives places an emphasis on ensuring that their IT equipment is well maintained and secure in order to serve patrons. As the growth in database records and total gigabytes of data managed has grown, so too has the amount of State Archives IT equipment and the maintenance requirements for that equipment. The State Archives currently predicts that spending on IT equipment will remain high in the next several years, as new equipment continues to necessitate the installation of new computers for both compatibility and security purposes. The State Archives should comment on what specific equipment is approaching the end of its useful life, as well as what can be done to prolong the life of existing equipment without compromising cybersecurity protections. On page 9, we see that the operating budget recommended action is to concur with the governor's allowance, and I'm happy to take any questions. Thank you.
Thank you, Mr. Polikoff. And seeing no questions, Madam Archivist.
Thank you, Chair McCray, members of the subcommittee. For the record, I'm Elaine Rice-Bachman. I'm the Maryland State Archivist. With me today is Assistant State Archivist Emily Olin Squires and Director of Administration Teresa Fawley. Assistant State Archivist Corey Lewis is supporting his daughter on a college interview today. So we're sending good vibes to him. I want to thank Jacob for his excellent analysis and for taking time over the year to meet with us and spend time at our facilities. I also want to thank you, Chair McCray. Since our last hearing, since last year, you've spent time at both our facilities at down the street on Rao Boulevard and out at Rolling Run and Woodlawn. And I really appreciate you coming to see our operations there. You have my full testimony, so I will only remark briefly on the 2 areas we were asked to comment on in our budget. I do want to take a point of privilege to thank the General Assembly and the Governor's Office last year for providing us with a generally funded PIN to support criminal research, which specifically deals with federal, state, and local background checks for gun ownership. This allowed the archives to hire an experienced staff member into this role, which directly led to over 1,300 requests being completed and eliminated a backlog of requests within 6 months. We also found new efficiencies with that new generally funded PIN to add additional duties to that team, including handling of expungement requests and taking criminal records requests from the public that require in-depth research. So I just want to assure you that money was well spent and we are grateful. We were asked to provide a note about our public programs with some concern about how we report attendance, and we will consider new ways to track that. But we are also working with DBM to consider updating our MFR measures to be more meaningful in terms of how we really fulfill our core mission of public access to records. And I note in the written testimony some stats from FY23, but I think they bear repeating that in FY23, our staff hosted 3,072 in-person visits to our agency, 31,952 virtual reference sessions via email and telephone, and filled 12,836 records order requests. Coupled with our other group presentations and educational programs, these efforts result in over 47,860 personal outreach points to the public. And that doesn't even count all of the other programs that we do throughout the year, the exhibits that are seen in the State House, et cetera. So, but we will consider how we can better track all of that interaction to ensure that we're meeting our core mission. The second request for commentary is the far more critical one in terms of budget planning, and that is to address the life cycle of our IT infrastructure, what we are doing to prolong the life of this equipment, and what the needs and costs for replacement and upgrades are. And what are the risks for not replacing that, both to our core mission of records preservation and access, but also to cybersecurity. In the written testimony, we respond to the specific information about which IT equipment is currently where it is in its life cycle, where we foresee in the next 4 fiscal years replacement being necessary. I would again note that last year we were given some additional funding to be able to replace one of our servers. That was extremely helpful. Each of those servers, which is bears the majority of our expenses in IT, require changing out over every 5 years. So that's just going to be a cyclical arrangement. And I would just really note that while we all move toward a paperless government and more electronic records, paper records are much less expensive to maintain than electronic records. So while there will be less of a need for physical space over time as more records are made electronic, those electronic records need a lot more care and feeding than paper records. A paper record, a box of paper records could sit on a shelf for 100 years and barring natural disaster, or fire or flood, need very little maintenance. An electronic record has to be updated. It has to be verified routinely. The equipment that it sits on has to be changed out because we, as the receivers of all those electronic records that must be permanent, have to be able to maintain them and make them accessible for posterity. We're thinking about the next 100 years, not the next 10 years. So it's really essential that we have the funding over the next fiscal year and beyond to continue maintaining that equipment and to plan for an increase in electronic records as more agencies become paperless. So with that, I will take any questions that you have, and thank you very much.
Thank you, Madam Archivist. Seeing no questions, I'm going to go straight to comments if that's okay.
Thank you.
I just want to lean in and say you've been probably one of the most rewarding agencies switching over to the subcommittee to be able to learn what's going on with the respective agency. I can't thank you enough. And I'll just lean in and say I was overwhelmed with the level of intentionality that your agency presents. Just the partnerships that you all have was pretty cool to be able to see. Just in watching your leadership and watching the folks that's working under you and their level of intentionality. Unfortunately, I didn't get to see the Baltimore space. I look forward to seeing the Baltimore space during this interim, but hoping that we will continue to model what it should look like in reference to our archives and a level of partnership, intentional partnership that takes place currently, and look forward to what that brings in the future. I didn't understand the technology that was moving forward and how you guys are still preserving that. I didn't know digging deep into the relationship with MSP. And as you talked about, as we move with the changes in Supreme Court laws, how we have to adapt with that. So I just say thank you, thank you, thank you. And to Mr. Polikoff, just thank you for the second year, just being able to work with you and understanding what our archives are doing and being able to dig into the agency. I say thank you for that also. Colleagues, seeing that this is, there was no questions, let's move to the second agency. We'll go to the Maryland Department of Health, Public Health Administration, and we'll call up Ms. Naomi Kamara.
Okay, thank you, Mr. Chair. My name is Naomi Camaro. I'm a budget analyst with the Department of Legislative Services, and I'll be presenting the budget for the Public Health Administration. So the fiscal 25 allowance includes $274.7 million for PHA, which is an increase of $12.4 million from the working appropriation. On page 3, Exhibit 1 breaks out the spending for fiscal 25. The largest portion of funding is directed towards the local health departments through the core funding formula. Nearly a quarter of the budget is allocated to personnel in the various offices that are included in this budget, which include the Office of the Chief Medical Examiner, the Laboratories Administration, and the Office of Preparedness and Response. On pages 4 and 5, we've listed out the major changes between the allowance as proposed and the working appropriation. Driving much of the increase are increases in personnel costs. MDH is adding 115 new positions under PHA. There's also some increases in federal funding through CDC grants to local health departments to strengthen the public health workforce. And this increase is partially offset by some decreases due to the expiration of stimulus funds. Turning to page 6, begins a discussion of personnel. So as I said, MDH is adding 115 new positions under PHA. This is offset by 5 transfers out of PHA to other offices within the Department of Health. And these positions also include 18 that were created by contractual conversion in fiscal 24. We have asked MDH to provide a breakout of the new positions and their functions and indicate which were created through contractual conversion in fiscal 24 and which will be converted in fiscal 25. Next, regarding vacancies under PHA, as of December 2023, there were 50 vacancies in this budget for a vacancy rate of 11%. We're asking MDH to clarify the number of vacancies in the offices included in the PHA budget and explain which were created by contractual conversion, or which of them, if any, were created by contractual conversion in fiscal 24 to understand if those new positions are vacant. On the next page begins a discussion of the Office of the Chief Medical Examiner. This is really an update related to the autopsy backlog that started in fiscal 2021 and a couple of updates to some of their operational procedures. So over the last decade, the office has seen an increase in cases coming into the office, as well as been affected by the nationwide shortage of medical examiners. The exhibit on page 7, exhibit 3, shows the number of deaths that have been investigated by the OCME, as well as the percentage of cases that have been examined within 24 hours of receiving them. As you can see in fiscal 2021, the office had over 25,000 cases. And in fiscal 22, the percentage that were examined within 24 hours dropped to 79%. As of July 1st, 2023, OCME does no longer have a backlog of cases. And I'll discuss some of the vacancy issues related to this in just a minute. So one of the metric that MDH utilizes is the ratio of medical examiners to cases annually. This is also used by the National Association of Medical Examiners, which administers or provides accreditation to medical examiner offices across the country. And they want to make sure that medical examiner offices are retaining a medical examiner to caseload ratio of below 325 cases per year. So the exhibit 4 on page 9 shows the number of examinations performed under OCME in each year, as well as the ratio of cases performed annually by each medical examiner. During the COVID-19 pandemic, you can see in fiscals 21 and 22, OCME exceeded the name threshold for ME to caseload ratios. But during this period, name relaxed those did not enforce those standards due to the COVID-19 pandemic, so OCME retained its accreditation. Let's see, as of August 31st, 2023, OCME submitted paperwork to renew its accreditation and had an inspection scheduled for earlier this month on February 9th. On the next page, I'll just mention the vacancy rate at OCME. So OCME has struggled, like I said earlier, to hire and retain particularly medical examiner staff in recent years. But over the last year, the office has managed to decrease its vacancy rate by 8 percentage points. Including, I should also add, hiring a permanent chief medical examiner. And that position had not had a permanent person in that role for several years. On the next page, I mentioned a couple of operational changes to the office. First is that legislation in 2023 renamed the Postmortem Examiners Commission to the Postmortem Examiners Advisory Committee and transferred responsibilities of that entity under the Department of Health. We've asked MDH to comment on any operational and staffing impacts on the department due to this change. Secondly is related to a settlement that was decided in fall of 2023 arising from the Attorney General's review of some of the office's autopsy findings. There was a settlement that was decided in November related to the family of Anton Blacks, challenging the findings of the OCME, and BPW approved 2 settlement payments in November totaling $235,000 for Anton Black's family and legal representation. The settlement also required the OCME to adopt a set of reforms to its processes and procedures, and we're asking the office to discuss any other additional requirements of the settlement, including any operational changes. The next issue in this analysis relates to the local health department funding formula. So as I said, this is the largest share of the PHA budget. Local governments receive state funding according to a funding formula that takes into account population and inflation. And they also supplement this with federal and local funds. In addition, any local health departments that employ state employees receive COLAs and salary increments, just like any other eligible state employee would receive. And of course, this is different by jurisdiction because different jurisdictions employ a different number of state employees. Statute mandates that the core public health services funding reach 70 million in fiscal 25 and 80 million in fiscal 26, but it doesn't specify if prior year COLAs and salary adjustments are included in the base to which the formula growth is applied. And this has been applied differently and inconsistently in recent years. In fiscal 25, that growth factor was not applied because without the fiscal 25 COLAs and increments, the amount distributed to the local governments exceeded $70 million. On page 14, we've broken out the funding in fiscal 24, 25, and then what we would expect for fiscal 26. So you can see the bottom part of these bars on this chart represents the prior year base. In fiscal 24, there was a formula growth factor applied, and then there's also the prior year adjustments. And so if you factor in the prior year adjustments, the amount distributed exceeds the mandate in both 25 and in 26. So we would also expect the formula growth to not be applied in fiscal 26. However, because of the inconsistencies in calculating this formula in recent years, DLS is recommending adding language that would restrict funds pending a report on the funding formula methodology and application. Finally, I'll just briefly talk about stimulus funding. So funding from the Coronavirus Aid, Relief, and Economic Security Act provided quite a bit of money to PHA in fiscal 2023. And so federal funding from this source decreased by about $179 million between fiscal 23 and fiscal 24. The fiscal 25 budget includes about $5 million in stimulus funds. And so I'll just close by saying that DLS recommends concurring with the governor's the governor's allowance and adopting budget bill language that would restrict funding pending the submission of a report on the local health department's funding. You can take any questions if there are any.
Seeing no questions at this time, if we can call up the agency, Dr. Herrera Scott.
I was whispering to our Chief of Staff, Erin McMullen, after your praise for the prior agency. I'm afraid we're going to look like slackers up here. So good afternoon, Chairman McCray and members of the subcommittee. Laura Herrera Scott, Secretary of Health. One, thank you as always, Naomi Kimura, for your analysis. We really appreciate it. Allows us also to do our own 360 of the work that we're doing and learn from what you guys put forth. So thank you. We're going to be going over the Public Health Administration budget. With that, I'm going to turn it over to Deputy Secretary Dr. Kalyana Raman to do the overview, and then we'll both be available for questions.
Thank you. And thank you, Chair McCray and members of the committee. For the record, I'm Dr. Nilesh Kalyana Raman, the Deputy Secretary of Public Health at the Maryland Department of Health. And I too want to thank Naomi Kimura for working with us and for this analysis. We've shared some materials and our analyses. I'm not going to read through all of them. I just want to highlight a few items for the committee. We've had under Public Health Administration, we have a wide range of programs. The two items that are not here or other hearings we had, which was for our Prevention Health Promotion Administration and Office of Healthcare Quality. This constitutes the remainder of the work under Public Health Services. And that includes our Laboratories Administration, Vital Statistics, Office of Population Health Improvement, our Office of Provider Engagement and Regulation, our Office of Preparedness and Response, the Office of the Chief Medical Examiner, our State Anatomy Board, and of course, our local health departments. And so I just wanted to touch on the local health departments and OCME, just because I think that they're top of mind. And so our local health departments, there's one in every one of the 24 jurisdictions, and they're funded through a range of state, local, and federal funds. And as Ms. Kimura noted, they have differing staffing patterns, with some having exclusively state employees and some all the way at the other side of the spectrum where they have at most one state employee, typically the health officer, and the remainder are county employees. They provide a range of services. There's a core set of services they provide around chronic disease management, cancer prevention, vaccinations, environmental health services, local addiction authorities. And then, of course, each health department has their own special either programs or services that are in response to the jurisdictions that they are in. The Office of the Chief Medical Examiner is the other area I wanted to touch on. Over the past year, we've invested a lot of time and effort in addressing personnel and operational issues there at the office. And I can tell you that we've seen some improvements, some significant improvements. Namely, we now have a new Chief Medical Examiner, Dr. Stephanie Dean, who's been in this position now for almost 6 months, but has an extensive history with the office for many years and is a fantastic leader. And we're really excited to have her in this role. We've strengthened our ACGME accreditation, having gone through our survey this past summer. We've invested resources, staff resources, to be able to work through our processes, our policies, and make sure that we are keeping up with our accreditation. That is critically important because the fellows that we train are a key source of staffing for our medical examiners. We are one of the few, if not the only, standalone forensic medical pathology programs in the country. And that is reflected in the fact that 3 of the 4 fellows that we have this year will be joining our staff come the end of their fellowship in this July. As Ms. Kimura noted, we also went through our our National Association of Medical Examiners re-accreditation, and they were here just about a week and a half ago. And the visit went well, and we'll of course hear from them as follow-up. But these are the kinds of efforts that keep our quality up and are important for us to continue to invest in. Switching over to the analysts' points. I just want to touch on a couple of them. One is related to the OCME and the question around the effect of changing the role of the Postmortem Examiners Commission. They were responsible for personnel and staffing, while the department was responsible for day-to-day oversight and execution. That was a challenging role. So actually this change that has happened to make them an advisory council has streamlined our efforts to oversee and manage the Office of the Chief Medical Examiner, and actually made it easier for us to put into place the changes that are needed to improve their functioning. The other item I wanted to highlight was the DLS recommendation to have a report on LHD funding formula methodology. We concur with this. We are looking forward to doing that report. The history of this funding over the past almost 30 years, about 28 years. There's a lot of opportunity here to clarify where we are now and set ourselves up to going forward. And with that, I'm going to stop here, and I'm happy to answer any questions you have.
Senator Hettleman.
Thank you very much, Mr. Chairman. Thank you for your presentation. As you might imagine, there's a lot of confusion from the local health departments. And so I wonder if you could clarify before this report that digs into the matching formula, kind of what your expectations are with regard to what their payment will be based on. And given that I know my county is in the midst of putting together their budget now for presentation, I think in early April. I imagine every county is. So kind of, I think some of them are quite fearful that they're going to have pretty substantial jumps in their obligations, and obviously for planning purposes, et cetera, and their expectations, it would be helpful to know sooner rather than later, A, what it's based on, and B, kind of what the expectations are.
So I can give you a little bit of insight into that. There's 2 elements to this. One is that each county has to do a match do a match for state funding. The percentages that each county have to match are different across counties. And that has been set along the way. That was initially set in 96, and there have been a few small changes along the way that have never increased the percentage match, but have decreased it. And I think that's one of the issues we want to dig into. And so there's two components to this. One is that whenever the state allocation increases, the amount that has to be matched increases, right? And I think what we saw with this past budget is that there was a pretty significant increase in funding towards local health departments, which was welcome as an investment, but meant that counties then had to increase the amount of match that they put into it. But because that budget was finalized at the same, during the same time the counties are finalizing, it led a few counties to be in a position where they had a significantly increased amount that they had to match. And that was challenging for them to do after they had closed their budget period. Now, I think one of the key details here is that many counties overmatch, which means that they put in more money to the health department than is strictly required. And so for a number of counties, that increased requirement wasn't a challenge because they were already either meeting or exceeding that. For some, which were closer to the required percentage, that was a challenge. So that's one element of it. And I think that while we would welcome additional investments, it's unlikely we'll see such a sharp increase in the amount of funding. And certainly this budget doesn't envision such a sharp increase as we saw in the prior year. The second.
Can I just add also the difference in the budget was in the original projections that they had that they were looking for the match on. The plan was that state employees were getting a 3% COLA, but not the state employees at the local level. And we went back and forth with DBM, given the equity of being a state employee regardless. And so that drove up the final number, which then created some of the hardships in the match because it wasn't planned for. But we did it to make sure that the state employees at the local level were given, just to clarify why it was unexpected.
So you wouldn't anticipate that going forward because there's not going to be that same kind of jump. I mean, in salary, et cetera. Correct?
That would be our guess. But again, to your original question and what Dr. Kalyanaraman was saying, I think we need to look at the percentages. The percentages were originally baked in 1996. There was some changes in the early 2000s and they actually went down. They did not go up. They never went up. And so whether or not we need to look at that again based on the counties and what the state is bringing or the mix of county state employees, but we need to look at that, which is why we concurred with the recommendation about a report, because we're looking at it now already. And it's in everyone's best interest to figure out how did the county balance their budget while we're also trying to make sure they're adequately resourced from our perspective.
Okay. Thank you.
Senator Zucker.
Thank you very much. Good to see you all. Just wanted to get clarification. So appreciate you saying how important the report is going to be. Are you Department of Legislative Services is recommending a $250,000 restriction based on the report? Are you okay with the restriction too, or just? I just wanted clarification on that.
I mean, I think we'd rather not have a restriction,
Okay. I was just because it says the department concurs with the report, which I get, but I wanted just clarity on the restriction piece too. Okay. So your thing would be yes for the report, obviously, but no on the restriction. Okay. Thank you. Thank you, Mr. Chairman.
Thank you, Senator Zucker. Madam Secretary, just a couple questions. One of them is we talked about the forensic pathology fellowship program, and it sounds like it's a phenomenal opportunity to make sure that we're thinking about what does the workforce look like and that pipeline look like. If you all could just get back with Ms. Camaro in reference to just the demographics of the 4 people that you were discussing. I'm curious about what does that look like. Also like geography, like do they reside in Maryland? If so, what counties? How are we moving from that piece will be very helpful. Madam,
just on that one point,
yes,
we can definitely provide you, but the pool of pathologists that we pull from is in the hundreds.
Okay.
So it's not like other specialties where there's a lot of residency program and fellowship programs for this particular. I think there are probably less than 500 medical examiners statewide. So to Dr. Kalyana Raman's point, having the fellowship actually helps us create the pipeline. But we don't get a lot of flexibility on who's coming into the pipeline because not many people choose pathology as a career.
Yep.
Okay.
Yes, ma'am. We didn't talk about MLART this time and just wanted to see if we can get a status update on MLART.
Sure, we'd be happy to send that to you, a status update on where we are with that.
Okay. I did want to send a congratulations in reference to the OCME and just the direction that we're going in reference to OCME was pretty helpful.
That's all Dr. Kalyana Raman, just to make sure you know who's the one that's been driving that train and getting that ship righted.
Very important and keeping us out of the headlines in a good way. So thank you. Just in reference to Senator Hedelman's questionings around our local jurisdictions, local health departments, we received a letter from Worcester. I don't know why I have a tough time getting it out, but they talked about their budget. Obviously, when you followed up with her, you talked about like it's happening during that budget cycle and everybody likes some type of certainty, some type of clarity. But they talked about how their obligation went from one spot to 2.5 times more than what they were doing. If you could comment, like how do you foresee helping to assess or take care of a gap like that when it's 2.5 times more than what the expectation was? They talked about the hearing, I guess, in appropriations, talked about the report that would be released from you at some point in time. But when do you all have a definitive answer in reference to the local jurisdiction being able to know when they would know what their match looked like?
So the match is once the budget is passed, that's when we can give them the final number. What we have communicated with health officers is this is what's in the, what's in the governor's allowance. And so these are projections, but we can't finalize those numbers until the end of session.
You want to talk about how you're helping minister by getting them passed?
Yeah. The other item is that, we've, for a number of jurisdictions this fiscal year who have asked for relief because of the increase, we've actually given them an exemption to contribute the same amount in fiscal 24 that they did in fiscal 23, so that the amount didn't increase and they were able to meet that. So, we've tried to be flexible with this. And certainly that's why I think this study is going to be important to see what the percentages should be as well going forward.
Got it. Senator Hedelman.
Thank you, Mr. Chairman. Just one more follow-up. How many jurisdictions are we talking about here that have substantial changes? Do you know?
So we saw that five counties had expressed the interest in having some relief, and we talked to them about the fact that we expect you to at least look to FY25 to be able to plan for this number, certainly, right? And then depending on what comes out of the budget hearing, we'll see, the final budget, we'll see where they land. Some of those dollar amounts were smaller in the orders of a few $100,000, right? That is much more manageable with a year of planning. Some were much larger, like Worcester's noted, which were multiple millions of dollars, which even with planning is still a difficult lift. And so, we're taking it on a case-by-case basis to manage this.
One more follow-up. Do you anticipate having this report on the local matching, the formula, well in advance of planning for next year's budget?
I think our expectation is to have it by the fall. There's a date in there that I just don't remember off the top of my head, but
I'm sorry, September, October. Okay.
yes.
Thank you. Thank you.
Madam Secretary, seeing no more questions, we do have one piece of public testimony. So if you could just hang out for one moment and I'm gonna call up the person where you're sitting at.
Do you want me to leave?
Yes, ma'am. At this time, I'm going to call up Ms. Ginger Noble, Ask Me Local 354.
Good morning, Chairperson McCray and the committee members. My name is Ginger Noble, and I am the president for AFSCME Local 354. So I have Washington and Frederick County Health Departments. I'm also one of the regional vice presidents for AFSCME Council 3, which goes from Frederick County to Garrett County. So I have multiple health departments in my region. I'm also asking that we support consistent pay raises for the local health departments. And I very much appreciate Secretary and Deputy Secretary of Health for their support of this. Our employees were frontline workers before there's a phrase frontline workers. We have the social workers, LPNs, office clerks, peer recovery specialists, Medicare associate program assistants, associates, WIC specialists, environmental health aides, community health outreach workers, and they all perform vital tasks in our communities every day and have been for a very long time. In recent years, in the past, there's been back and forth when we've negotiated raises, and I've sat in on those negotiations. Whenever I sit in, I negotiate for all of my members, not just a select few. And that includes all the members of the health department. These raises need to be in our budget. On page 13 of the analysis, they reference uncertainty in future years, and I'm asking you to please make sure that those health departments are included consistently every year from here on out. Our employees need to be treated like every other state employee in the state, and they need to be included from here on out whenever we negotiate with the state. Thank you.
Thank you, Madam President. Seeing no questions, just wanted to say thank you for your testimony. Madam Secretary, just thinking about some of the bigger agencies, we follow them each and every day. It's the little agencies you just don't give as much attention to, which is what caught me off guard. Madam Secretary, I think that you know this, but leadership, one of the fine qualities of leadership is putting together a great team. And I do think that you're building an all-star team over there at the health department, which is why we see it going in the right direction. As we spoke about just with OCME. Ms. Camaro, just want to say thank you again for helping us to see the in-depths of what we could improve on, some of the challenges, but also our strengths within the agencies. Colleagues, seeing that there's no more questions, we'll bring up the next agency, which is Maryland Health Regulatory Commissions. And we're going to ask Ms. Ann Braun, to read out the report.
Thank you, Mr. Chairman, members of the committee. Hope you're having a good afternoon. Today, as you said, I'm here to present the budget analysis for the health regulatory commissions under the Department of Health. And so this covers 3 independent agencies within MDH. This includes the Maryland Healthcare Commission, the Health Services Cost Review Commission, Community Health Resources Commission, and then it also includes the Prescription Drug Affordability Board. The fiscal 25 allowance for these offices increases to just under $350 million. That's almost entirely in special funds. Moving to the fiscal 24 discussion that starts on page 2, the fiscal 24 budget includes $1 million in general funds added by the General Assembly for Prescription Drug Affordability Board operating costs. $614,000 of this was used to reimburse the Maryland Healthcare Commission, MHCC, for special funds that it contributed to support operations while the board was establishing a funding source. Remaining funds support salaries and allow the board's special funds to pay for other uses like website improvements and new databases. On the next page, there's a discussion on the proposed deficiency of $5 million for MHCC, and that is supported with MEMSOF, or Emergency Medical Services Operating Fund, to increase the operating grant for the Shock Trauma Center. This is also related to a fiscal 24 legislative addition, as general funds budgeted for the MEMSOF included language to ensure that fiscal 24 shock trauma the fiscal 24 shock trauma operating grant would total $8.7 million. And so this deficiency brings the grant award to that amount. Moving to the fiscal 25 allowance section, exhibit 1 on page 4 shows the largest components of fiscal 25 spending. That includes $135 million for the uncompensated care fund. That's distributed by the HSCRC to hospitals for care that they don't receive compensation for. So that includes things like charity care, financial assistance, and bad debt. The budget also includes 110 million in blueprint funds for the consortium on coordinated community supports. Going to jump ahead to Exhibit 3 on pages 6 and 7. This shows the proposed budget changes between fiscal 24 and 25, and that totals a net increase of about 50 million. This is mainly due to increases of $23 million for the uncompensated care fund, $8 million, an $8 million increase to support the state's designated health information exchange, or CRISP, and then $25 million for the consortium. This is partially offset by a decrease of $5 million for the enhancement for the shock trauma operating grant in fiscal 24 that I mentioned. At the bottom of page 7, this begins a discussion on the consortium. This is a initiative within MCHRC, which was created as part of the blueprint, and it was created to meet student behavioral health needs through community supports partnerships. The proposed budget includes 85 million in fiscal 24 and 110 million in fiscal 25, mainly to support the consortium's grant program. There's a provision in this year's BRFA that would expand the use of these grants to provide school-based behavioral health services and to reimburse the Maryland Department of Health for the state costs of school-based services covered by Medicaid. Currently, Medicaid only covers school health services required for students with individual educational plans, or IEPs, or they can cover services that are directly billed by community providers. MDH indicated that it is working to apply for federal approval beginning in calendar 25 to expand Medicaid coverage to services provided by school psychologists and social workers and for services for students who don't have IEPs. MDH estimated that this expansion would cost $12.7 million in general funds and starting in fiscal 25. And so that could be reimbursed with blueprint funding if the BRFA provision is enacted. If the consortium spends blueprint funds to reimburse MDH for the state share of those costs, then that funding would also receive the typical federal match on Medicaid spending, so a minimum of 50%. In August 2023, the consortium issued an request for proposals for services grants supported with funds, both that were carried over from prior years and fiscal 24 funding. And so Exhibit 4 on pages 9 and 10 show the funds requested through that RFP totaling over 380 million. And then $136 million in grant allocations were recommended to advance. After this report was drafted, the consortium announced that $111 million in grants were awarded across 129 grantees. And so that grant detail is available on the MCHRC's website. The consortium also released an RFP for grants to local behavioral health authorities and local management boards to serve as hub pilot programs to coordinate the service grants. MCHRC is asked to clarify whether the first round of service grants spends all of the carried over funding and the fiscal 24 amount, and then is asked to discuss the timing and criteria for awarding grants with the fiscal 25 funding. DLS also recommends adopting committee narrative that would request a report on the consortium grants. So then I'm going to move ahead to the key observations section that begins on page 13. This first item discusses state funding for trauma centers. And so in Maryland, MIMS designates hospital facilities as trauma centers if they meet certain regulatory standards. And the centers are further classified with the highest designations of Primary Adult Resource Center, or PARC, and that's the Shock Trauma Center. And then there's also level 1 centers having some of the higher designations. Some trauma center costs are covered through hospital rate setting that's regulated by the HSCRC, but other costs like on-call physician rates fall outside of that authority. MHCC and HSCRC manage the Maryland Trauma Physician Services Fund, which can subsidize some of the unregulated rates and other costs. So those are listed on page 13. That fund is supported with a $5 surcharge on vehicle registrations. Exhibit 5 on page 14 shows the fund's revenues, which are typically around $12 million, but was supplemented with $4 million in general funds in fiscal 22. So mostly due to that one-time general fund appropriation, the closing balance increased to about 7.5 million at the end of fiscal 23. The exhibit also shows how the fund was distributed across uses, and those uses are decided by MHCC and HSCRC However, they must meet specific requirements in statute for the allocation methodology. The fiscal 24 budget bill included $9.5 million in general funds paid into the dedicated purpose account to further support the trauma facilities experiencing financial challenges. MHCC was required to submit a letter to the budget committees explaining the allocation methodology for this funding, since it didn't have to follow that same methodology as the Trauma Physician Services Fund. This letter was actually just submitted last week. So it's not noted in the analysis, but it has been received at this point. And then there have been recent efforts to study the adequacy of state funding for trauma centers through a commission that was required in 2023 legislation. So at the time of writing this analysis, the commission's final report was not submitted, but preliminary findings were presented at a appropriations committee hearing earlier in session. And so these findings included, they're shown on page 16, and it included that about 50% of readiness costs are currently funded through the Trauma Physician Services Fund and HSCRC regulated hospital rates. The preliminary recommendations are also listed, and that includes increasing on-call and standby physician payments, adding flexibility for MHCC and HSCRC to modify the Physician Services Fund allocations, and having HSCRC audit MIMS incremental trauma costs, which is another way that regulated hospital rates have covered some trauma costs. The shortfall in trauma readiness costs is estimated at 18 million, and that doesn't include the shock trauma physicians costs. And HSCRC also reported that it would need to further analyze other recommendations before providing a detailed cost estimate. MHCC and HSCRC are asked to discuss any plans to implement the commission's recommendations, including whether any departmental bills will be introduced during the session for any changes that would require legislation. MHCC is also asked to discuss changes in revenue sources that were considered by the commission, such as changes to the vehicle registration surcharge. So now I'll move on to the second key observation that begins on page 17. This discusses a letter that MHCC submitted to the budget committees as required by fiscal 24 budget language. The letter discusses regulations for implementing connectivity to health information exchanges and networks that restrict data for patients who have obtained legally protected healthcare. And so this is related to requirements in chapters 248 and 249 from last year that was related to MHCC's expanded role to establish standards to protect the confidentiality of patient and healthcare practitioner information related to that protected care. MHCC's proposed regulations were published on January 12th, and the commission discussed working with health information exchanges to comply with the new requirements, but reported that some of the exchanges would need more time to update their systems. And so DLS found this letter to be in compliance with the budget language and recommends the release of special funds. And so if no objections are raised at these budget hearings, we'll draft a letter to that effect. And then moving on to key observation 3. This discusses the total cost of care model. That's the state's agreement with the federal government to control the total cost of care for Medicare beneficiaries, improve care outcomes, and population health. Under that agreement, Maryland must meet certain Medicare savings targets and other measures that are outlined in Appendix 3. Generally, Maryland met 3 targets in calendar 22, but missed its goals of for readmissions, and then experienced a second year with higher Medicare growth than the national growth rate. And so this missed a goal referred to as the guardrail. In calendar 23, HSCRC had tracked preliminary Medicare savings data that would have missed the performance targets. And so they took the actions that are listed on page 19 to increase savings. So following these efforts, Maryland is now expected to meet calendar 23 savings targets. The next discussion, starting on page 20, is on the Maryland Primary Care Program. This program is federally funded and offers incentives to primary care providers to deliver advanced services with the goal of improving priority population health outcomes. It should be noted that payments through this program count toward the state's Medicare spending. And so Exhibit 6 on page 21 shows HSCRC's analysis on the cost effectiveness of this program. And it found that the incentive payments have led to growing net Medicare costs rather than savings that would help the state meet its targets. HSCRC is asked to comment on potential changes to the program to make it cost effective. And DLS is also recommending narrative, requesting HSCRC to consult with the program's management office within MDH to submit another report on this program to continue monitoring its cost effectiveness. Page 23 begins a discussion on population health efforts under the model. This includes outcome-based credits that offer Maryland the opportunity to earn credits for Medicare savings if they meet certain population health goals. So far, Maryland has received federal approval for one of 3 potential credits, and that credit focuses on diabetes prevention. However, the calendar 22 credit results have not been finalized. HSCRC plans to propose opioid use disorder and hypertension as the other 2 credits, but ran into delays with that approval process. And so the commission is asked to comment on any fiscal impacts of the delayed proposals for outcome-based credits. On page 24, there's a brief description of HSCRC's planning activities for the transition out of the total cost of care model and into the next federal agreement. And so HSCRC is asked to discuss the timeline, federal review process, and stakeholder feedback process for implementing a new model. The 4th key observation discusses the Prescription Drug Affordability Board's recent activity. The board is authorized to conduct cost reviews of identified drugs that may cause affordability issues and then could draft a plan of action with criteria to support upper payment limits, specifically for prescription drugs purchased by state or local government and the Medicaid program. Most recently, the board finalized cost review regulations and expected to implement the cost review process starting early this year, with the first set of cost reviews expected to be concluded by the end of calendar 2024. And so with that, page 26 shows the 2 recommendations for committee narrative that I discussed in the presentation. But other than that, I'll conclude. I'm happy to answer any questions.
Seeing no questions, Ms. Braun, at this time, let's bring up the respective agencies.
Well, it's today. Yep, I think we are. No, I think that's enough.
Good afternoon, Chairman McCray, members of the subcommittee, and thank you as always for your detailed analysis, especially with all the boards and the number of moving pieces. I did want to point out that the 3 health regulatory commissions are independently run and governed. However, the department works closely with these commissions on important policy issues facing Marylanders. So I did want to highlight one partnership, even though we all work with each other, based on the questions that were asked, and that's related to the next negotiation for the Maryland hospital model, and in particular, our application to CMMI for AHEAD. And what AHEAD stands for is the state's advancing all payer health equity approaches and development model. It's an 11-year voluntary state total cost of care model that seeks to drive state and regional healthcare transformation and multi-payer alignment to accelerate transformation across the entire healthcare system. Full disclosure, when you read the notice of funding, it reads like the Maryland model, and CMMI is looking to scale that across multiple states. But they've also made it clear this is the vehicle that we need to use to renegotiate the terms of our total cost of care model. And similar to what we've been doing, the AHEAD model is designed to curb healthcare cost growth, improve population health, and advance health equity. It has some additional requirements, especially around the integration of behavioral health and a statewide health equity framework. So our expectation is to submit that application by March 18th of next month. I did want to take or provide responses to the few of the questions as they relate to the MD primary care, the Maryland Primary Care Program. As noted in the budget analysis, Maryland has a robust Medicare primary care program that is administered by the Maryland Department of Health in partnership with the Center for Medicare and Medicaid Innovation. So it's MDH and CMMI that administer the Maryland Primary Care Program. The goals of the program are not just cost savings, although I'm happy to go into reasons why the costs might be higher than expected or not completely mitigated by the savings in the program. But it was also to increase access to quality primary health care. It was also to improve health outcomes, and it was also to improve the patient experience. So CAP scores related to their contact with the primary care system. Through our own current contract and also through HHS, CMMI is encouraging Maryland to broaden the program so that multiple payers, including Medicaid, have similar aligned programs. Maryland Medicaid, as is required by the current Maryland model contract with the federal government, must implement an aligned primary care program and is working to do so by January 1 of 2025. So this goes to some of the questions around what transformative initiatives are we going to pursue. There are some requirements in the current model contract, but certainly ahead has been defined some of what that should look like, and we're actively working on that already. Now, there was also a question about evaluation of the MD primary care program. I'll defer to HSCRC on the specific request for comment. However, I want to highlight that MD-PCP is pursuing an independent evaluation this year, and the state will be working closely with the Federal Center for Medicare and Medicaid Services to evolve MD-PCP during the HED implementation. And we expect that report to be due on June of 2024 of this year. And with that, I'd like to turn over remarks to the other independent commissions to comment specifically on their work and the questions raised by Ann. Thank you.
Good afternoon, Chairman, members of the committee. My name is Ben Steffen. I'm Executive Director of the Maryland Healthcare Commission. And while the Maryland Trauma Commission funding group was working, I was also co-chair of that along with Dr. Ted Delbridge of the Maryland Institute for Emergency Medical Services Systems. That is the group that completed the report that Ms. Wagner mentioned earlier. I want to first off commend Ms. Wagner for a very comprehensive and thorough evaluation of the MHCC's responsibilities. It is daunting, and I'm always impressed at how thorough and complete her analysis is. I want to note that my testimony is included in your materials. I'm not going to go over that in any detail, but would note that the commission this year had a very busy year, referenced by in the materials. You'll note that we produced approximately 15 reports to the General Assembly, in addition to our normal responsibilities, which include regulating the health information exchange framework in the state, CRISP and other technology operators, overseeing our health planning functions, reporting on cost and quality, and also conducting various analyses using what's called an all-payer claims database, which is a comprehensive system of claims covering public and private payers in the state. A couple notes on that. Those reports, 5 of them focused on healthcare mandates. It looks as though there's greater interest in expanding the scope of insurance coverage in the state. 5 of our studies projected the impact on premiums for if those mandates were adopted. I would note that every mandate seems important and is important for some consumers, but cumulatively they can have a significant impact on premiums, and we typically will note that as we move forward. A couple other important reports that are going to be triggering legislation focused on nursing home acquisitions in the state. The challenges that we've encountered during the pandemic have been highlighted, particularly in patients who are individuals who are in nursing homes. At the same time, challenges for operators has led to the acquisition, the sale of some, acquisition of some by out-of-state operators. There's great interest in having the state play a larger role. We convened a large work group of all stakeholders, including 3 representatives from the General Assembly. That has led to a report that is now the topic of legislation that will be considered before the General Assembly this session, that will provide for additional authority on the acquisition process as we move forward. I'd like to turn now to the questions that were posed by the analysts, specifically largely related to the trauma system. The trauma system has been an area that the Maryland Healthcare Commission, as well as HSCRC, have paid a special attention to over the last 20 years. The Maryland Trauma Physician Services Fund, established in 2003, has provided additional protections for Maryland trauma physicians, be they operating at the primary adult resource center, shock trauma, or a level 1, 2, or 3 throughout the state. Those payments subsidize physicians who provide uncompensated care or who provide on-call or standby services to the hospitals. As a result of concerns that have been raised by the trauma community, the commission was formed and began operation in August of 2023. It met 5 times between August and December. A series of recommendations were presented. The focus of those recommendations were, perhaps not surprising, increased funding levels and give the commissions greater flexibility on how those funds should be distributed. The overall financial estimate pegged potential losses through trauma at approximately $62 million, 18 of which relates to standby and on-call cost. The remainder is pegged, and I'll use this term euphemistically, incremental trauma cost, which means typically additional costs that were they a hospital, not a trauma center, would not have been incurred. Hospital finance is tricky, as Dr. Crum will tell you, and how those incremental costs are actually factored warrants further consideration before we move forward necessarily with automatically funding the financial information that the 10 trauma centers provided. But we are encouraging HSCRC. It is their responsibility to fund actual hospital costs, and these incremental trauma costs are hospital costs, to consider whether they would be funded. We also recognize that if we're talking about more funding, we're also talking about a revenue source. Currently, the only funding for trauma occurs through a $5 biennial assessment on automobile registrations and registration renewals. If we move forward with additional funding for in particular, on-call cost, we will need to look for additional revenue sources or potentially raise the fee that automobile owners pay when they register or renew their automobile registrations. We would estimate that approximately the fund, if it's to be funded fully for the on-call cost, would need to generate another approximately $8 to $9 million, which would probably mean that the existing $5 fee would climb to $9 to $10 per biennial renewal. We also, as part of that trauma commission, did consider other revenue sources. Keep in mind that automobile accidents are a significant cause for use of the trauma system. Other other events, mechanisms, if you will, include firearms, but the most significant is falls. Now we think of falls from construction sites, falls from people on their roofs, but it actually also includes falls from people, elderly walking, injuring them. They can be injured quite severely. We looked at the mechanisms, and the commission did believe that of the mechanisms for which an assessment could be pegged, firearms and firearm accessories and ammunition did represent a potential candidate for additional revenue sources. As some of you may be aware, there is legislation introduced by Senator Alfred that does impose an excise tax on firearms, firearm accessories, mag loaders, scopes, potentially even things as obnoxious as bump stocks if the Supreme Court does reverse federal legislation that made them illegal, as well as ammunition of all types. That is working its way through the legislature. Certainly when it comes to falls, there is a significant mechanism, but no one is suggesting that we put a tax on canes, wheelchairs, and other walking devices. Some things just can't be assessed in that way, but certainly mechanisms such as firearms do pose a potential opportunity here. Secondly, the Trauma Commission also noted that there does need to be a rethinking of just what our standards are for trauma care in the state. Currently, Maryland has a nationally respected trauma system. It was noted by some of the operators that our standards are higher than what are required by the American College of Surgeons, who administers trauma standards and accreditation nationwide. What was told to us at the commission was, yes, indeed, a level 2 in Maryland is really a level 1 minus in the rest of the country. I think the standards that we have established here in the state have served us well, but it is the responsibility of MIMS to convene the regulatory review process that would look at standards moving forward. We certainly did not bring all of the appropriate individuals to really delve into standards themselves through the Trauma Funding Commission, but that is an appropriate next step that could go on. There was general recognition that additional funds are needed. The commission has completed its work for now, but I would note that it does not sunset until June of 2024. We also, the analyst mentioned that we've also sent to the chairs of appropriations and budget and tax committees our recommendations on dividing $9.5 million among the 10 eligible trauma centers. We concluded that there was financial need across the system and developed a 3-factor allocation program that would, first of all, consider that there was need throughout the system. Approximately 50% is divided equally among the 10 centers. And then the other 50% is divided up 25% based on from lower to higher, a recognition that lower level trauma centers have a greater percentage of their costs that cannot be recovered through reimbursements. So it was proportionally weighted. So lower level trauma centers would receive greater amounts of compensation through that component. And then conversely, we looked at patient acuity that are showing up at the trauma centers and weighted the other 25% based on the actual acuity of patients arriving at that system. It's kind of interesting to know that we take great pride in our specialty hospital in Maryland, our only specialty hospital. Unlike other states, we don't have heart hospitals. We don't have joint hospitals. We have a trauma hospital. We should be very proud of that. But we should also take note that many of the level 2 centers in particular, sprinkled throughout the state, suburban in Montgomery County, Prince George's, CAP region in Prince George's County, and 2 level 2s in Baltimore, are what I call the workhorse trauma centers in the state. And they have increasingly taken on very, very complex trauma care as the need has grown. And it's important to see it as we move forward, the holistic nature of our trauma system, that all of the trauma centers count. Lastly, I would note that we are successfully moving forward with the legislation adopted last year covering protected health information. And we have worked very carefully with the information technology firms. Initially, it was no, we can't do this. But through discussions, careful interaction, listening to their concerns, we developed regulations that have now been published and are moving forward with plans to implement those requirements, which I think are very important, but technically somewhat challenging for the industry. It used to be said last summer, impossible. Now we're hearing that it can be done, but in some instances in an incremental process. So I want to thank you for your indulgence today. Happy to take questions at the conclusion or immediately at the indulgence of the chair.
Good afternoon, Mr. Chair and subcommittee members. My name is John Crom. I'm the Executive Director of the Health Services Cost Review Commission. And first, I would like to echo Mr. Steffen's thanks to Ms. Braun for her thoughtful analysis. HSCRC is an independent state agency responsible for regulating the quality and cost of hospital services to ensure that all Marylanders have access to high-value healthcare. Among our core functions, the HSCRC sets global budgets on hospital revenue and services and plays an important role in managing the state's total cost of care model agreement with the federal government, as the secretary noted. The model brings many benefits to the state. The model improves the quality of care in hospitals and in primary care. The model equitably distributes funding for uncompensated care through the Uncompensated Care Fund, which supports equity and access to hospitals. The model also equalizes hospital charges for all payers, including the uninsured, and helps control healthcare cost growth in the state. And since 2014, we've been able to maintain all payer hospital cost growth below the state economy's overall growth rate. And we are on track to meet our target for 2023. The model also allows us to invest in population health, including maternal and child health. With that, I'll turn to the questions asked of the HSCRC in the analysis. And first, with respect to the primary care question, primary care and specialty physicians are really important to the success of the total cost of care model. I know that you have our written response that concurs on evaluating the MDPCP program, as we've done in each of the past 4 years. However, upon further consultation with MDH, we understand that the independent evaluation that they are planning will be duplicative to the analysis that HSCRC has done in the past, and we would respectfully request that the committee rely on the MDH independent evaluation. We would also submit that MDPCP should be viewed not only by the cost of the MDPCP program, but also for the improved outcomes for patients, given that MDPCP physicians are accountable for the quality of the services that they provide to patients. Additionally, just to note, MDPCP has reduced hospital utilization by 2.66%, or about 114 million. And that Maryland's investments in the MDPCP program also have not prevented the state from meeting the total cost of care model's annual Medicare total cost of care cost savings targets. And finally, it's important to note that as the secretary mentioned, MDPCP has a robust governance structure between CMMI, MDH, and an advisory committee run by the MHCC to consider policy or programmatic enhancements. Second, regarding the process and timeline for implementing a new Maryland model, again, as the secretary mentioned, we're happy to be partnering with the department in applying for the Notice of Funding Opportunity, or NOFO, for the AHEAD model, which again is a multi-state initiative aimed at curbing healthcare cost growth, improving population health, and advancing health equity. So, AHEAD is the pathway for continuing Maryland's all-payer total cost of care model that advances the vision of equity and excellence in Maryland's healthcare delivery system. And in fact, as discussed, the multi-state AHEAD model is principally based on what Maryland has built in the total cost of care model. So the NOFO asks interested states to describe their general approach, experience, and capabilities to be successful in the AHEAD model, given that the basis for the model really relies so much on what we've built here and what we've had in place in the state. We think we're well positioned to submit a successful application. And again, that deadline for that submission is March 18th. MDH and HSCRC have convened 3 committees to advise the state in the development of the state's AHEAD application. One of the committees is focused on getting feedback on the primary care components of the application, one on the population health and equity components, and then the third is focused on hospital global budgets and other healthcare transformation efforts within the model. If CMS approves this initial application, we would expect to hear that over the summer, and then negotiations over changes to the total cost of care model to occur over the next 18 months or so, with the updated program to be implemented in 2026. Third, regarding the recommendations of the Commission to study trauma center funding, HSCRC certainly supports additional funding for the Maryland Trauma Physicians Fund. Increasing the trauma fund is a critical path to mitigate risk to the sustainability of our trauma system, and is crucial in providing high quality care to patients. And as Mr. Stephan noted, additionally, some trauma costs are funded through regulated hospital rates, while HSCRC does not have legal authority to set rates for physician costs, which are a substantial component of the increase in trauma costs over time. We are committed to a process of reviewing regulated funding for trauma centers and considering our policy approaches to funding trauma services through hospital rates. And then finally, regarding the fiscal impact of the delay in finalizing outcome-based credits, outcomes-based credits are an opportunity for the state to essentially receive retroactive scoring of additional savings under the total cost of care model for improvements in population health. Since we've consistently met those cost growth targets of the model, and again, we're on track to hit those for 2023 as well, CMMI has prioritized finalizing these methodologies. And I'd also note that they don't directly impact hospital global budgets. So we really expect that there will be no fiscal impact from the delayed submission of the 2 credits that are currently in development. However, that being said, the credits can be applied retroactively, and we do intend to continue our work with CMMI on the hypertension and opioid outcome based credits, because those methodologies could be important for assessing the impact of hospitals' population health efforts in these areas. So with that, I want to thank the committee for your time and support of the HSCRC, and happy to answer questions at the conclusion of the panel.
Okay. Thank you, Mr. Chair and committee members. My name is Ed Casemeyer. I'm chair of the CHRC. I want to thank the administration for their allowance, and thank Ann for her comments and analysis of our budget, which we concur in, and Mark will be glad to answer any questions you may have. In recent years, our budget has expanded significantly, and we now have several programs under our direction. We want to thank the General Assembly for having the confidence in us to give those responsibilities to us. And our staff has really done a tremendous job in working to fulfill the needs for these programs. We have 3 programs. One is the original grant of $8 million that we started with in 2005. And our fundamental objective is to provide medical care to underserved communities. And in that initial grant program, we've provided over 800 grants worth about $240 million to all 24 jurisdictions in Maryland. And we've serviced about 525,000 people. Secondly, we have undertaken to support the work of the Health Equity Resources Communities initiative that you passed several years ago. That was made up of 2 programs. First was called Pathways. Those were awarded a couple of years ago, and they're going to end up this spring. And we're now entering into the awarding of the HERC grants. Very recently, we had 59 applicants for about $290 million. Actually, we only have $42 million to award, so that selection process is underway. And third, as was mentioned by Ann in her comments, we have the Consortium on Community Supports, which was part of the Kerwin initiative. That consortium is chaired by Delegate Rudolph, who some of you may know. Just last week, and the purpose of the consortium is to provide behavioral health services and wraparound services to every K through 12 student in Maryland. So we developed a system of hub and spoke, which we're trying to change the name of those 2 components. But just last week, we awarded 129 grants using $111 million for the service aspect of those grants. And we are now underway considering grants for the hubs. And they, I think we'll be finalizing that. What the commission has, and they'll be announced. Actually, we're having a press conference tomorrow to announce those. So with that, I ask Mark if he wants to make any comments.
Oh, sure. Yeah, I'll keep my remarks very brief. I'm happy to respond to the questions raised by DLS. Just a couple of thank yous. First, I want to thank my chairman. There's been a lot on our plate over the last 12 to 16 months. In fact, over the last 6 months, we've had over 680 million in funding requests over the different programs that Chair Casemar said. So to have a steady hand at the wheel with Chair Casemar is really great. So I just want to thank you publicly. Second, I want to thank the administration for their allowance and Governor Moore for giving us the support that we need to implement these 3 programs. I also want to thank Secretary Scott and her team. She's given me 2 appointees, one of whom's in the room, Aaron McMullen and Ryan Moran. They serve on the consortium. This consortium is a lot of work and it's great. And so to have our colleagues from the health department and from the Department of Education, great group of 20 people. Just want to thank you publicly, Secretary, for your active support on the consortium. A lot of work to do. We're just in year 2 of a 10-year program. So thank you for that. And then finally, I just want to thank the Department of Legislative Services. I agree with every word that Ann said in her analysis, and I'm happy to respond to the questions she asked, which is largely an update on the work of the consortium. That sound good? Okay, so we fully expended the 23 allowance, which is 50 million, and then the allowance in 24 is 85. So when you add up those 2, it's 135 million. And as Chair Casemar said, we completed the first round of services grants, which is 111 grants, 111 million, 129 across the state. If you sort of look at all 129 grants, we are really grateful that there was in every area of the state, Allegheny all the way down to Somerset. And it's just very diverse. And we're really excited to get these programs launched with the contract period beginning March 1. So 129 grants start this school semester, and they'll continue on through the end of next school year. As Chair Casemar said, we also have another grant. In fact, we're going to start to finalize recommendations tomorrow at the next meeting of the consortium. We'll see you, Aaron and Ryan, to look at the administrative oversight in these local communities. That first RFP was open to local behavioral health authorities and local management boards. We had 17 proposals requesting 9 million, and it's a pilot, so we're going to select 10. And those final, those initial recommendations will be tomorrow. And we're happy that it was a diverse group of organizations, local behavioral health authorities, some which are nonprofits, some of which are some of which are government, and some of which are local management boards, just diverse all areas across the state. Anne had asked about the timing for the fiscal 25, which is the allowance you have before you. So that grows to 110 million. And our plan is, with permission of the General Assembly, to use the unexpended funding in 24, which is about 10 to 11 million dollars, and apply that to the services grants. And the reason that we're confident that that's an appropriate use of the funding is because I said earlier, and in Anne's analysis, in that first RFP, just the first year, 380 million was requested, and we could fund about 120 million. So in scrutinizing those projects, we feel that in providing technical assistance to the unsuccessful applicants, there'll be more than enough demand to award the funding. And there's also the BRFA item that was mentioned in Anne's analysis. So with that, I would be happy to answer any questions, and it's good to see the members of the subcommittee and you, Mr. Chairman.
Thank you, Mr. Chair, members of the committee. Thank you for the opportunity to speak with you today. My name is Andrew York, and I'm the Executive Director of the Maryland Prescription Drug Affordability Board. We are the first in the nation independent agency dedicated to making prescription drugs more affordable for Marylanders. I'd like to thank Ms. Braun for her wonderful analysis and support through a number of technical questions I had, so thank you. Thank the administration for the allowance, and then also thank the Department of Health for their wonderful partnership, continued partnership, especially the Maryland Healthcare Commission. They were kind of our host agency as we were getting off the ground. We continue to be very close partners. Their all-payer claims database in particular is a essential resource for our work. We have an exciting year ahead. We are beginning our cost reviews, where we basically get to select a series of drugs and understand if they cause any affordability challenges. And we're also working on our upper payment limit action plan, which will talk about how we would set upper payment limits for state and local government. So we hope to have that done this year. And with that, we're here to be a resource for you, and we look forward to making prescription drugs more affordable for Marylanders. Thanks.
Senator Hellman.
Very much. Thank you very much for this comprehensive report and for all you do. And I just want to say thank you, especially to Mr. Steffen. I know it has been a challenge on the protected health data legislation from last year, and you have moved mountains. So I really do appreciate that. Thank you.
Just a couple questions in reference to like the grant agreements that we give shock trauma, the 8.7 million, the 5 million. When we do those grants, is there some type of contingent where we get a report out of how that grant money was spent and if it was what they said that it was going to be spent on?
Oh, sorry, I was looking to Mark to answer that. Could you repeat the question again? I'm sorry. I was like, Mark, are you going to answer that?
All right. I wasn't looking to Mark. So with shock trauma receives grants from the state of Maryland. I'm under the perception that when they receive these grants, I don't know whether they are different contingencies. You talked about on call. You talked about things of that nature, like some of the dire needs that's within shock trauma. What are they spending it on when they get the grant? And is it what they're saying? And do those funds supplant? Do they supplement? Like, how do you all write out those grant agreements, and how do you get reports out of how that grant agreement was getting spent?
Thank you for the question. I apologize for my lack of attention, but the responsibility that MHCC has to the transfer of the MSOF funds to shock trauma is really very limited. Our authority is we act as an intermediary between DBM and shock trauma, that typically we would get a authorization to move those funds from DBM and it would just be transferred. We don't do any confirmation that funds to shock trauma are spent appropriately. They are operating funds for shock trauma. But in terms of confirmation, it was my understanding that the MHCC was asked to do this because of our role in trauma, but it was the opinion of DBM that they wanted to have an opportunity to transfer them into a operating budget. But the expectation would be once authorized, we would make the transfer. I can get back to you. I don't believe we receive any documentation from Park in terms of how those funds are spent, but that no reports is what I've been told. So yeah, we act as basically the intermediary between the Department of Budget Management and Park, but don't make an authorization to move those funds until we receive approval or authorization to do so.
Is that an appropriate agency that you believe that once a person gets a grant agreement that should come through, just to say what the outcomes was?
I think that's a good suggestion. I would want to go back to DBM and make sure that they're not making those determinations and not forwarding them, but I can follow up with you. I think that's an important suggestion, as it seems to be that for many years, the funds were 3.5 million, 3.4 million. They've been increasing recently by about 100,000 a year, but the last year it was much more substantial. I think it's going to revert back to funding levels that have been historically present. But I think your point is a good one of who's actually looking at how park spending is actually allocated at that important facility.
Second question is going to go towards the 57.8 million for diabetes prevention, and I'm not looking at you. Can you just report out in reference or elaborate, like, who were the grantees? What was some of the outcomes of the 57.8 million that was dispersed?
Yeah, absolutely. So this was one of our regional partnership programs. And for that program, it was really looking at 6 regional partnerships around the state. And generally those partnerships were staffed by hospital staff. The outcomes that we were looking at were really enrollment and then some financials on delivering DPP services and other diabetes prevention services. One of the challenges that we saw was that enrollment numbers and completion numbers in those programs consistently across all 6 programs were very, very low, right? So what we did this year was look to, given that performance, and then also the concerns around sustainability over the long run, largely due to billing those services through commercial insurance and others. We're winding down that program, and then we will be working on the commission to figure out what's a good replacement for those funds going forward, or should those be reverted to future savings in the model.
Follow back up before I get to the next question.
Yeah, please.
If you can get with Ms. Braun, if you can lay out the 6 partnerships, what was the dollar amount appropriated to the specific ones, and any type of extra reporting pieces of it when you talked about those outcomes that you just hit on right now, would be helpful. The second question in reference to the $10 million around maternal health, can you just lay out the outcomes? How did it go? How did it get dispersed and things of that nature?
Certainly, I can work with Ms. Braun on those as well. That program has a number of different reporting elements, and we can provide a summary of those.
Perfect. Oh, yes, sir. Mr. Stephan, order appropriate person, but I think it says your name at the top. This report came out February 13th, but you all had the information, I guess, as early as December. Was it any reason why the legislature received it in February versus December?
So the complexity of the incremental costs that can be related to trauma required several rounds of questions back from the facilities. Ultimately, the additional time we needed was really valuable in terms of getting a better handle on the overall cost. I think we went back 3 times to some facilities to try to get them to clarify what their cost, their incremental costs were. An example, and I've talked about the level 3s, the level 2s already, but among the level 2s, there was a variation of between 1.5 million in incremental trauma cost at Capital Region to about 9.5 million at Johns Hopkins Bayview in incremental cost. Oftentimes, one would expect consistent, relatively consistent cost across entities that are pretty much doing the same thing. So we did go back repeatedly to ask questions. That was one of the major causes for the delay.
Got it. When you elaborated on Johns Hopkins, baby, because I was curious about this statement that you made on page 2, the MHCC staff observed that virtually all trauma center hospitals, except for Johns Hopkins Hospital Academic Center, experienced significant unregulated operating loss. Could you just speak to why they're outlier?
So that comparison looked at the hospital's total operating cost, operating revenue, total operating margins, total margins, and the academic center does appear to be doing not just for trauma, but overall, this is for their entire book of business, if you will. They look like they were doing better. It's a much, much larger facility with a broader scope of services. And that was the basis for what we said, that they did appear to be generating positive margin, whereas almost all of the others were not. And in specifically where we saw losses, where were in their non-regulated services, which could include, almost certainly does include their physician payments that they couldn't recover through reimbursements what they were paying out for physicians in compensation. So that is a broad problem across hospitals in the United States, that as they have moved forward with acquisition of physician practices, that oftentimes for care delivery, that makes some sense. The health services research literature is replete with articles about whether that makes sense financially, but many hospitals find that when they acquire practices, they do not generate sufficient revenue from billing to fully cover the cost of the compensation levels that they're paying those physicians.
When I look at the trauma report that you guys just released, when on page 27, it lists out the trauma centers, and then I look at shock trauma. This graph that you have on table 10, it says Maryland trauma standby payments through hospital rates. And when I looked at shock trauma for fiscal year 2021, it went $1 million plus. And then when it went to fiscal year 2022, it went 2.6 million. And when I looked at all of the rest of the other trauma centers, no one had that substantial of an increase. So I just wanted to understand what happened fiscal year 2021, 2022, that one specific center had that much of an increase.
So the legislation, initially, shock trauma was not eligible for standby expenses. Legislation that was adopted, I believe, in 2018, made them eligible to receive standby expenses. We worked with shock trauma in collaboration with HSCRC. Remember that standby can be included in hospital rates because it's covering cost for services at the hospital. On call, which pays physicians for being off-site but ready to respond within 30 minutes, cannot be considered a hospital cost. So the differential really just represents a partial. 2021 was a partial year. 2022 was a full year. And moving forward, my expectation would be that the standby cost at shock trauma would look pretty similar to what you see in 2022. Now, keep in mind that there are, recommendations from the Trauma Commission that additional funds be available for standby, but I think the one-time blip you see is due to implementation.
But thank you. That definitely helps, and I can see it a lot more clear after that response. My last final question is the recommendations as you speak of. Some of them I understand why that it takes legislation or things of that nature, but I saw a number of them that I thought that you all may be able to do within respective agencies, and just wanted to get your opinion because I listened to your response, but I really didn't hear any specifics about some of the low-hanging fruit, may I say. When you talk about D2, recommendation D2, HSCRC should audit the incremental hospital costs associated with the trauma service. If I can get you to comment on that specific recommendation.
Yeah, I would yield to Dr. Crump, but
yes.
Yes, we that was a recommendation. We don't think that requires legislation. And it should be noted. If it wasn't, it was our mistake, but it does not require legislation, I don't believe. Dr. Crump.
No, so with respect to that recommendation, there are a couple things that we can do and we'll plan on doing. When we say audit those costs, it's really two things, right? One is looking at trying to reconcile what they self-reported in the survey to the Trauma Commission with what they report to us in their cost reports. They're very different types of reporting, right? The reporting that they do for us is on their kind of essentially their total regulated book of business, right? So we have to pick apart, are they, assigning costs in this survey related to incremental trauma costs here, but in our cost reporting, it sits within, for example, the ED service line, right? The entire emergency department. We'd have to do a little bit of work to disentangle some of that. The other thing I would note too is because of the global budget methodology, the global budgets aren't set on a direct cost basis, right? So in other words, the global budgets increase by a number of factors related to the needs of the population rather than on an item by item service line by service line direct cost basis, right? So they don't report their costs and then the rates go up by that cost. That's a key mechanism by which we're able to manage cost growth going forward, right? So in my comments, what I'm suggesting is that we would do that that kind of reconciling of what they reported and what they report to us, and then we would look at kind of adequacy of the rates going forward within the context of those population-based methodologies.
So in layman's terms, would you consider that an audit?
I would. It would be an audit of their cost reporting, sure. Okay. Certainly, yeah.
The second one was number E, conduct biannual audits to confirm the managed care organizations are reimbursing all trauma providers at Medicare rate.
So in 2017 and 18, some of the trauma centers came back to us and said that the trauma flags that are required in their claims to MCOs were not always recognized and therefore paid at 100% of Medicare. Under the law, trauma services to Medicaid beneficiaries are to be paid at least at 100% of Medicare. The argument from the trauma centers was that was not always happening. We did ask Hilltop, which is is a contractor for the Medicaid administration, to do a review. They did identify a substantial amount of underpayment, which we then retroactively paid to the trauma providers. Since that occurred, Medicaid has elevated the payment rates to 100% of Medicare. Keep in mind that the trauma fund only pays the gap between what the Medicaid program pays and 100% of Medicare. And as Medicaid has moved to 100% of Medicare, the obligation of the trauma fund to pay any of that diminishes. And as you can, I think in the report, we note that it's only a couple $100,000 currently. But we think it's warranted to continue to keep our eye on what the MCOs are doing, because they account for the bulk of Medicaid reimbursement to trauma centers.
And would you guys be conducting the biannual?
So initially we did what I would call a data audit, and we would work with the department to determine who is best situated. Very likely, in any event, it would be Hilltop that would play a key role. There is an interagency agreement that Hilltop has with the department, but we would want to work with them to make sure that that all works out. Potentially, the cost of this could be charged back to the trauma fund.
Got it. The last two, G1, align the trauma data systems with MHCC and HICRC data systems to enable more complete analysis of trauma care costs.
Again, not a requirement, not a statutory change,
right,
but we are moving forward across the state in better integrating data systems. One of the challenges we did find was pegging the total trauma cost for certain types of trauma episodes. We could determine that through our review of HSCRC data, but that only includes hospital cost. It doesn't include physician cost, which we could get from other sources, including our all payer claim data. And what we suggested is that MIMS work with us and CRISP to assign an encrypted patient ID so that trauma registry could be better linked with other data systems, and we could get a better idea of trauma cost across the spectrum, even from the standpoint of after hospital discharge, because significant numbers of trauma patients, particularly severe traumatic injuries, require substantial rehab costs that were not captured in some of our estimates on gunshot wounds. That we said gunshot wounds are some of the most costly trauma care, but we're only talking about hospital costs. We couldn't put a peg on physician cost, pharmacy cost, rehab cost.
So it's accurate to say that you're supportive of G1?
Yes.
And the last one, G2, is very easy. Will you be looking into that work group that is being recommended to be convened?
Yes, we've talked already with MIMS about convening a work group. I think as we consider additional funds for the trauma system, we think it's appropriate that the trauma system be accountable, and looking at quality and outcome measures, I think, are extremely important, particularly as we likely would see, as we do in the entire healthcare system, disparities in care that result. And we'd like to be sure that if additional state funds are awarded to trauma centers, that they're accountable for that.
Thank you. And seeing no more questions at the time, Madam Secretary, just thank you for what you do. But to each and every one of the independent agencies, thank you for what you do. But Mr. Chair, please don't get up too quick. I wanted to say that if there was a gold star to be given out, I definitely would go to your respective independent agency. Your director is definitely a gem. I wasn't as familiar with everything that was going on over at that agency, but during the interim, I believe several times been able to be enlightened and understanding the important work that's going on is deeply thoughtful. The last piece is that not only did he help me understand the agency, but some of the work that was going on in my own district I wasn't aware of, and going out and seeing a facility was very, very thoughtful, but definitely a relationship that I've been able to continue to cultivate with that respective organization. So I say thank you.
He gives the extra mile, no question.
Yeah, yes, he does. And Ms. Braun, just thank you for all the calls and accepting the calls to be able to understand some of the stuff that I'm reading at this point in time. Colleagues, we have one more left. And this will be the last one. Department of Human Services Administration, Ms. Natalie Andrade.
Thank you, Mr. Chair. Good afternoon. My name is Natalie Andrade, and I'm here with the Department of Legislative Services to present the fiscal 25 allowance for the Department of Human Services Administration. The Department of Human Services Administration provides direction, coordination, financial services, information technology management, and overall operational support for all DHS programs and activities. On page 1 of this analysis, you can see that the fiscal 25 budget decreases by $75.7 million to $306.3 million. The fiscal 25 allowance decreases across all fund types compared to the fiscal 24 working appropriation. And the decrease in fiscal 25 allowance is mainly driven by the proposed deficiency appropriation of $72 million related to the maintenance and improvements to the Maryland Total Human Services Integrated Network, MD-THINK. Now I'm going to jump to page 4 of the analysis, where there is a discussion about a performance measure related to the children receiving appropriate care. The Citizen Review Board of Children reviews cases involving children in out-of-home placement and makes recommendations to the local departments of social services to ensure the provision of appropriate educational and health services. On page 5, Exhibit 1 shows the percentage of cases in which children receive appropriate educational services, in which children receive appropriate physical and mental health services, and the out-of-home placement cases with reports submitted to the local department and the courts within 15 days of the review. Related to the percentage of cases in which children receive appropriate educational services, the blue bars, and there had been some fluctuation there. It has decreased from 94% in fiscal 19 to 62% in fiscal 2022. This also shows an improvement in fiscal 2023. This reached 79% in this year in the fiscal 2023, and DHS explained that this improvement is due to the inclusion of a new unit under the Social Service Administration denominated Audit Compliance and Quality Improvement Unit, responsible for monitoring educational services entries by the 24 local departments of social services. This unit expanded its monitoring practices to include educational records, resulting in an increase in local departments' engagement with an attention to educational services. Despite this improvement, the percentage remains below the pre-pandemic levels. Related to the light blue bars, related to the appropriate physical and mental health services, there has not been a significant improvement, and this has remained level at approximately 43%. Finally, the line in blue shows the information on the proportion of out-of-home placement in which reports were submitted to local departments and courts within 15 days following the CRVC's review. Timely report submission is crucial for the prompt coordination of services for children in out-of-home placement. The percentage of cases of reports submitted within 15 days has exhibited the positive trends, increasing to 89% and 83% in fiscal 22 and fiscal 23 respectively. DHS should discuss measures to sustain and enhance the timeliness of reporting by CRBC and strategies to enhance the provision of appropriate educational and health services. On page 6, there is a discussion about the proposed deficiency. The fiscal 25 allowance for DHS administration includes 3 proposed deficiencies. The first one is of $3 million for postage. This is explained by increased expenditures that were caused by processing unscheduled federally mandated mailings for Family Investment Administration and the Child Support Administration, and 2 increases in postage cost. The second deficiency of $1.8 million is for long distance and toll-free service charges. DHS indicates that these funds have been under budgeted for several years, and DHS has fallen behind on monthly invoices. Finally, the third deficiency of $72 million is for maintenance and improvements to MD-Think. According to DHS, this deficiency is to course correct and modernize the platform and to adequately staff each program under MD-Think. DHS should comment on the timeline for the expenditure of proposed deficiencies throughout the remaining duration of fiscal 2024. On page 8, Exhibit 2 shows the breakdown of the fiscal 25 allowance. As you can see, 44% of the budget goes to MD-Think, 29% goes to personnel, and other programs collectively make up 7% of the budget. Exhibit 3 on pages 9 and 10 shows the proposed budget changes. And as I mentioned before, the fiscal 25 allowance decreases by $75.7 million compared to the fiscal 24 working appropriation. And a significant portion of this change is explained by the fiscal 24 proposed deficiency related to the maintenance and improvements to MD-Think, which addresses gaps for staffing, consulting, and operational costs. As you can see, under MD-Think, there's a decrease of $62.7 million related to this deficiency. On page 10, under local general administration, there is an increase of $2.8 million related to new vendors for a contract to maintain and enhance the existing financial management system to contract utilized by the local Department of Social Services office. And under other changes, there is an increase of $7.5 million related to the renewal of the electronic benefits transfer system contract, and a decrease of $13.7 million related to the moving cost for DHS headquarters relocation. On page 11, on the personnel section, we can see that the vacancy rate as of December 31st, 2023 was 8.68% or 66 vacancies. Of these 66 vacancies, 43 have been vacant for less than a year, and 13 positions have been vacant for over 1 year. On page 12, on the issues section, we have the first issue that we want to present to the committees, and it is related to the implementation and challenges of the MD-Think program. The MD-Think is a shared technology platform that integrates multiple state health and human service programs and applications. Currently, all major DHS customer-facing systems are hosted on the MD-Think platform, and MD-Think's data, program, and applications are hosted on a cloud service provided by Amazon Web Services. MD-Think is staffed by 20 state employees from DHS and NDH, and by 350 staff provided by 13 vendors through a statewide contract. As of September 2023, DHS reported that MD-Think program is finalizing the design, development, and implementation of modifications to the system supporting DHS. Regarding the external utilization of the MD-Think, a committee narrative in the 23 Joint Chairman's report requested that DHS provide a report on the external utilization of the MD-Think platform and the cost estimates for the transition phase for each agency. So on page 13, exhibit 4, and also on page 13 and 14, exhibit 4 shows the list of the external agency products that have been fully integrated into the MDThink platform. And the total cost of this integration stands at $34.3 million. Similarly, on page 15, exhibit 5 shows a list of external agency products that are currently being implemented on the MDThink platform. And the total cost of this implementation is $31.1 million. This information is as of July 31st, 2023. So DHS should comment on the current status of the transition process to the MDThink platform, specifically concerning external agency products that were anticipated to go live between August and December 2023. On page 16, there is a discussion about the challenges that DHS has encountered on the implementation of the MDThink. And during the budget hearings for the DHS overview, DHS mentioned critical issues in MDThink's structure and operations, specifically related to the lack of oversight, financial overspend, and practice. These issues have led to rework and delays in addressing system errors and user experience concerns. Related to the lack of oversight, DHS mentioned that the lack of internal controls for spending, financial management, and cost allocation explain this issue, and this has led to overspending and projected inefficiencies. Related to financial overspend, there has been inconsistent management controls, reliance on labor hour contracted developers instead of commercially available off-the-shelf solutions, and a lack of accountability for system performance have contributed to rework and additional costs. And related to practice, the absence of proper testing led to applications being perceived as ready for production when they were not, causing rework, delays, and higher costs. Regular release of new features without adequate testing, resulting in bugs, defects, and inaccuracies. In general, the lack of coordination in system development has led to a situation where the components or modules of the system operate in isolation from each other, lacking effective communication or integration. This can make the system less user-friendly and more difficult to navigate. So DHS should comment on the correlation between the challenges faced and the proposed efficiency of $72 million for maintenance and improvements to MDThink. On page 17, there is a discussion about improvement efforts that DHS has been implementing to address the lack of internal controls, to address financial overspend, and to address the practice issues. So DHS should comment on the improvement efforts undertaken to address challenges faced with MDThink during fiscal 23 and 24, and highlight any milestones achieved since the identification of these challenges. Additionally, provide insights on any initiatives planned for fiscal 25 with a specific emphasis on whether the allowance adequately supports all planned activities. On page 18 begins the second issue that we want to present to the committees, and it is related to the oversight of the local Department of Social Services. In March 22, the Office of Legislative Audits published the fiscal compliance audit on the DHS local department operations. The audit identified 6 findings, of which 5 were repeated from previous audits. Language in the fiscal 24 budget bill restricted $100,000 in general funds pending a report on the department's efforts to improve the oversight of the local Department of Social Services. The submitted report is explained here, and from page 18 to page 22, there is a detailed description of all the action and efforts that DHS has implemented in response to the OLA recommendations. On page 23, there is the third issue that we want to present to the committees, and it is related to the update of the DHS headquarters building relocation. And as a background, the existing office facility is a century-old department store building that has presented substantial challenges in terms of infrastructure, foundation, and operational inefficiency. These issues have resulted in excessive maintenance and repair costs. So the agency decided to relocate to a newer rented space. Despite initial plans for fall 23 move, the relocation timeline was adjusted to approximately June 24. And this delay is attributed to challenges faced with the general contractor in navigating the building and fire permits. Related to the funds allocated for the move, these funds have been utilized to cover expenses such as professional services for tenant fit out at the new location, moving service charges, network infrastructure, computer equipment, and furniture. So DHS should comment on whether it possesses adequate funds to support the relocation. Furthermore, the agency should comment on any updates related to the date for the move. And to conclude, on page 24, we have outlined the recommended actions for the committees to take, which is to request that DHS submit a report providing information on the MD-Think's implementation status. And with that, I conclude my presentation, and I'm happy to answer any questions that you have.
Thank you, Ms. Andrade. Seeing no questions, Secretary Lopez.
Good afternoon, Senator and members of the committee. I'm Rafael Lopez, and I serve as the Secretary of the Department of Human Services. We're grateful to the governor, the legislature, and all the supporting staff for supporting the department in this work. Joining me today at the table are, to my right, Acting Chief Financial Officer Kirill Resnick. To my left, Deputy Secretary for Operations Dan Waite, and to his left, Pat McLaughlin, the new Executive Director of MD-Think. We also have behind us a crew of folks to help us out in case we need additional support answering your questions. Our administration teams provide the operational and technology-based services that enable us to serve over 1 million Marylanders a year. And we manage this through a state supervised and locally administered system. Our administration provides direction through 4 major units. Number 1, the Office of the Secretary. 2, the Operations Office. 3, local departments of social services in all 24 jurisdictions, and MD-Think. Together, these 4 units make it possible for us to deliver on the promise of the governor's vision to leave no one behind, deliver world-class customer service. In the spirit of being honest and transparent, as we continue to rebuild our relationships, I would be remiss if I didn't say that the particular part of this, of the department that requires us to continue modernizing and truly bring in the 21st century are the operations functions that our analyst has lifted up. Today, we'd like to highlight 5 interrelated areas. Number 1, investing in our local departments of social services. 2, reducing vacancies overall. 3, modernizing our budget and finance office. 4, reimagining MD-Think. And 5, transforming our customer service culture. Everything we do is about service. And ultimately, it is no secret that the Department of Human Services in the state of Maryland has struggled with this reputation of being following through, answering our phones, responding to our emails, and we are trying desperately to turn that culture around in partnership with all of our 6,000 team members across the state and all of our partners. Ultimately, Marylanders deserve nothing less. So the first item of investing in our local departments of social services. We work in partnership with nearly 6,000 members, as I've mentioned, across all 24 jurisdictions, and they are our boots on the ground. The majority of work that happens in community across our 24 jurisdictions. The majority of our interactions happen within the 24 local departments of social services. From planning department-wide initiatives to asking what computer equipment works best, or even basic budgeting decisions, we found a disconnect between what had been happening in the LDSS and what was happening on Saratoga Street in Baltimore. And we have made some significant changes and want to highlight some of those. Through 2023, we deliberately engaged all of our local office directors and invited them to the executive leadership team table. We were not going to be making both policy and practice decisions, even people decisions, without their full partnership. We have encouraged them as partners to help us shape what's happening statewide. And while that work is never easy, it's worth modeling a new way of governing. For the first time in years, every local director had the opportunity to put together their own budgets and to participate in our legislative bill review process. In fact, we launched a first ever transparent legislative playbook for the department for the first time ever. Everyone behind me, all the leaders across the state, have direct access to even how bills are being shaped and managed up to the legislature and the governor's office. Though none of this is perfect, it's just the beginning. And with the General Assembly's partnership, we'll do a variety of things this year, including feeding 500,000 Maryland children every summer when they're not in school, and really turning around this culture of a lack of engagement. Specifically on the issue of reducing vacancies, and second item I want to bring up, key to building local departments of social services for the long term is investing in people. And so we have taken the governor's charge seriously to reduce our vacancies, and we've done just that. On January 1st of last year, our vacancy rate was 15.2%. On the last day of last calendar year, December 31st, it was 9.69%, dramatically reducing our vacancies by 5.5%, equating to 338 net gain positions. And this didn't happen by accident. We continue to focus on our talent and intentionally tracking our vacancies and using every lever possible to make sure we're doing as many customer service facing positions, given our intentionality to turn around our customer service culture. Also rapidly prototyping ways to make sure that we're taking full advantage of all the levers available to us in Maryland. For example, same-day hiring, and working closely with the local departments of social services to attend career fairs and to be able to make offers on the spot. It's something we hadn't done before as a department. We're taking full advantage of now. To help us maintain this hiring momentum, the governor's budget also includes $19 million for employee and salaries general fund shortfall. This was mistakenly entered into our Family Investment Administration budget, but it's meant to support our hiring efforts across the entire department. We have alerted our DBM and DLS analysts to this data entry mistake and are working with them to course correct this. This investment allows us to focus on making sure that worker salaries are competitive in Maryland's really tight job market. And as we work to hire new staff, it is necessary to offer the job at higher steps in the salary schedule in order to attract and retain qualified staff. The third area we'd like to highlight is the importance of modernizing our budget and finance office. One of the greatest challenges we've faced in the administrative operations has been the reality of inheriting a budget and finance office challenged by outdated or non-existing business practices. The lack of budget transparency, strategy, or even a monthly burn rate dashboard has been challenging every step of the way. While this is absolutely not about blame or excuses, it has impacted our daily operations at every level. And to sort of put it bluntly, a deeply driven process by paper versus digitized and fully seamless in real time. These operationals have a direct impact on the people we serve. And from finding basic failures in our accounts payable section to how we actually reimburse and pay our contractors and vendors. To highlight one particular noteworthy example, in late August of 2023, there was over $2 million in unpaid Verizon phone bills dating back to 2022. All of these unpaid invoices were paper bills sitting on someone's desk. We made immediate course corrections throughout all of last year, including reimagining how we're engaging people at every level of our department, from our 24 jurisdictions to our state headquarter office in Baltimore. Our acting chief financial officer, Kuro Resnick, has graciously stepped up to help us during this transition period. We've implemented last spring a statewide delegated authority measures to be clear and in writing to hold each other accountable for who has the authority to act on financial matters. In the fall of 2023, we developed and implemented a new invoice submission process that is all digital through a Smart Sheets portal that our team developed itself. In fact, our Deputy Secretary Dan Waite was part of the architect of that because we had to move quickly and knew we didn't have time for procurement and put it all in place ourselves. Every invoice is now tracked and vetted through a standardized review process. And this should not be innovative in 2024, but it is for the Department of Human Services. We will finalize completing a line-by-line budget analysis of DHS and to fully implement and input the budget data into FEMIS, which is the state's current financial system. Unfortunately, DHS had not done that. Why this matters is that's how we'll set our burn rate dashboard so we can be much more thoughtful about how we report up, not just to use the legislature, but to the people of Maryland, and eventually have that all up on our website very transparently. On the fourth issue of reimagining MD Think, as our analysts mentioned, it is a shared platform that began in 2016 to modernize and integrate multiple state health and human services programs. And it provides a way for us to engage Marylanders in the provision of benefits. Since assuming office of last year, we have been examining all of MD Think's operations, which has revealed significant issues that we want to make sure and lift up to you now. Put simply, many of the applications are not working the way they should have or were reported in a public way. Working closely with colleagues Secretary Herrera Scott and Secretary Savage of Do It, we've found a lack of oversight and financial overspend. No cost savings were achieved through federal fiscal year 2022, and MD Think spent approximately 216 million more than anticipated on the platform to date. Upon discovering the issues, we made a variety of immediate course correction changes, including enacting leadership changes and building a new leadership team. As I mentioned, Pat McLaughlin is our new executive director. We reduced a budget shortfall that when we first came into office, we're told would be in the range of 100 million and reduced it to 6 million. And we wanted to remind each other that MD Think overspent in federal fiscal year 2022 by over $73 million. So we halted the creation of all new programs and applications to make sure we could focus on the ones we already had and making sure those work better and more seamlessly over the course of the next few months and years. We increased accountability around authorization of new expenditures. So for example, Pat can tell you to the dollar which budgets and which programs are moving where and when, and who has the responsibility for managing those dollars and those projects. We developed new critical positions to make sure the applications are working better, and we are not there yet. It's going to take some time to turn this around. In fact, we intentionally visited all 24 teams across the counties in the state of Maryland. We engaged our customers directly who use MD Think as a way to secure benefits, and we learned a lot from them, including the importance of strengthening our public-facing consumer portal. So we're partnering with Code for America to help us rapidly prototype new ways to engage. And in fact, MD Think was built not as a mobile-friendly platform. So that'll be one of the things we actually roll out in 2024 to make sure people can access their benefits from their phones themselves. This ties directly to customer service. As I mentioned, the importance of strengthening our customer service work. One is reminded of that by making sure Marylanders have access easily to how they ask for help and how they get it. On this fifth issue of transforming our customer service culture, we believe that language matters and how we treat each other matters. So making sure that when Marylanders call us for help, we are responsive in a timely way. Our call center receives over 5,000 calls a day from people all across the state. In fact, on Friday of this last week, we served 5,677 Marylanders. These calls range from asking about the most basic status of their application for SNAP benefits so they can put food on their tables to asking about the status of their child support payments. And we also get calls of desperation, specifically around helping them not have their electricity or their water or their gas shut off. How we signal with our actions and our words is really important. And the call center is but one of many ways in which Marylanders engage us, whether it's through our local departments of social services or calling us. And we want to make sure that the data we're learning helps us drive our strategy moving forward. And I'll start with one number to make sure we're crystal clear about this. 528,666. That is a total number of abandoned calls in 2023 alone. So over 1.9 million Marylanders tried to call the call center in 2023, and over 500,000 Marylanders gave up because they couldn't get a hold of a human. This included long wait times in excess of 15 minutes and peaking over 30 minutes at times, resulting in more than 10,000 calls being abandoned per week. Every day at my direction, our senior leadership team, those here in the room, as well as those across the jurisdictions, receive 3 complaints from Marylanders. And we use those 3 complaints per day to drill down into why it's happening, look at the root causes to better understand how we can turn this culture around and ultimately be more accountable. And the complaints range from the need to reschedule an appointment, whether it's for redetermination of a case, to saying that they got disconnected information from the call center to the local departments of social services, or trying to find out how to better engage the help that they need. And that's clearly intolerable. So we have a new call center contract that was just approved by the Board of Public Works on January 31st of this year. We have begun a 6-month transition period that will integrate a variety of more innovative customer service features for the state of Maryland. I'll lift up just a couple of them to model for you. We'll have an interactive voice response system and a customer relationship management system that is fully integrated with our MD Think applications. The system will also integrate, for the first time in Maryland's history, access for 3,200 of our team members to better understand what's happening and responding to cases in real time. This has never been done before, and we are going to desperately try to do this because it's what Marylanders deserve. Customers should be receiving and will receive the same information, whether they walk in the door, they call our customer service line or are accessing information versus the consumer portal. Marylanders deserve this. So our new service level agreements with our new contractor will hold the selected vendor accountable for goals, including achieving a 30-second wait time for 90% of incoming calls or face financial penalties. Modeling this value of moving with urgency is how we've modeled our RFP. And we moved from actually designing concept to getting it out the door in the first half of 23, releasing it in August. When those bids closed in October, we dedicated a full-time team to reviewing the proposals and finished those by November of 2023. We acted based on the needs of our customers as we listened to them across the state, and the contract was awarded to Automated Health Systems, or HHS, which was unanimously determined to be the #1 overall ranked offer by the evaluation committee. This particular vendor, AHS, proposes to actually locate their Maryland site at 250 Pratt Street in downtown Baltimore. They will hire over 200 full-time and part-time customer service representatives, which will be from Maryland. And we fully intend to hold them accountable for modeling DHS's MBE goals. They have agreed to the RFP's 25% MBE goal, as well as multilingual staff, including Spanish language staff at the call center for the first time in DHS's history. Help with things like resetting passwords to get access, rescheduling an appointment, are all things that should not be a luxury, and we're modeling new ways of doing this. With that said, I'm going to turn it over to our Acting Chief Financial Officer, Kirill Resnick, to briefly summarize our responses to the DLS analysis.
Thank you, Mr. Secretary, members of the subcommittee. Pleasure to be with you. Kirill Resnick, Acting Chief Financial Officer of the Department of Human Services. I'll quickly run through the 8 questions and recommendations that the analyst has posed to us. I will summarize as best I can, so please refer to your documents for more further detail. To question number 1 asks us how we should to discuss measures to sustain and enhance the timeliness of reporting by the CRBC. Although CRBC is housed within DHS's organizational structure, it is an independent entity overseen by their state board appointed by the governor. We've included a fact sheet on the CRBC as part of it as the attachments to our testimony for you to take a look at. The CRBC is required to provide a report to DHS and includes recommendations based on case reviews. DHS is required to review the annual report and provide a written response to the state board describing the actions to be taken by the department in response to the recommendations of that state board. DHS continues to enhance the provision of appropriate educational and health services. DHS's Social Security Administration implemented a new unit in 2021 called the Audit Compliance and Quality Improvement Unit. This unit is responsible for monitoring educational services by the 24 local departments of social services. In 2022, the ACQI unit added educational records to their list of monitoring practices. This monitoring practice has seen an increase in LDSS addressing educational services, with 22 of the 24 jurisdictions meeting their 90% threshold. DHS should comment on the timeline for the expenditure of proposed deficiencies for MD Think in the fiscal year 24. DHS anticipates that the expenditures of the proposed deficiencies during the remainder of FY24 will be accomplished no later than May 8th. DHS is proposing modifications to its task order contract to the Board of Public Works for its consideration and approval for 1 year, and adding $115 million to these contracts for the revised total contract amount of $561 million. Should these contract modifications be approved by the Board of Public Works and the relevant federal agencies, DHS will be able to expend all proposed deficiencies during this year. And in addition, there's attached letters to the Board of Public Works and the Department of Agriculture's Food and Nutrition Service that provides additional information. You'll see a breakdown in the testimony of how we intend to spend that money across the different funding sources and across the different partner agencies that contribute to MD Think. Question 3, we should comment on the current status of the transition process to the MD Think platform concerning external agency products that were anticipated to go live between August and December 2023. MD Think continues to work closely with external agencies to support development and hosting of these applications. Of the products that were anticipated to go live in that period of time, 3 are currently live, and the remaining products
product requirements receive scope modifications with new go live dates defined between the external agencies and MD Think. In your testimony, you will see a chart for all the different product suites, the start dates, the go live dates, and the estimated cost for those products. Question 4, to DLS's recommendation to adopt committee narrative requesting that DHS provide a report on the implementation status. DHS concurs and we will be happy to provide the report. DHS also thanks DLS for the adjusted due date of December 15th in order to provide a more comprehensive snapshot of project status and resource utilization. To question 5, DHS should comment on the correlation between the challenges faced and proposed efficiencies of the $72 million for maintenance and improvement of MD Think. If you can see our response to prompt 2 about these proposed deficiencies of $72 million, contrary to the previous assertions of DHS prior to 2023, design, development, and implementation work on the MD Think applications, including the 3 main applications of E&E, CJAMS, and CSMS, were not completed. As such, there exists a substantial body of work with program priorities that must be done in FY24 and FY25 to bring MD Think closer to the maintenance and operation status that we had previously reported. Question 6, that asks DHS to comment on the improvement efforts undertaken to address challenges faced with MD Think during fiscal 23 and 24 and highlight any milestones achieved. The MD Think team restructured, introducing newly created roles and distributed tasks more effectively across the organization and introduced a more mature implementation structure. MD Think team enhanced and transparency of the operational budget by implementing a near real-time budget tracker and spend plan dashboards. Furthermore, efforts were concentrated on stabilizing the platform and host applications, prioritizing improved architecture and design to enhance functionality and performance, and also while reducing costs. The analysis to address critical application bugs and defects resulted in a decrease in defects and time to resolution for FY25. Application design revisions and enhancements will further improve functionality. Finally, collaboration with partner agencies such as MDH, MHBE, DOIT, and DJS, aims to implement a more effective 360-degree view of residents, enabling unified benefit enrollment and auto enrollment services. To question 7, asking us to comment on whether we believe we have adequate funds to support our relocation effort. DHS intends to complete its relocation by June 30th, 2024, based on our latest construction and network equipment installation schedules and within the budget proposed by the governor. Finally, to the adoption of narrative with referencing MD Think's status and utilization of resources. DHS concurs and will provide this report. DHS once again thanks DLS for adjusting our due date to December 15th, 2024. And with that, thank you for your time. We're obviously open to any questions that you may have, and we encourage you to support the governor's budget.
Some very quick. On page 6, it talked about the program department in spring 2024, making them eligible hire for stipends upon graduation in May and June. Just hoping that I could just get an understanding of like the demographics and geographics from that piece.
Yeah, so the, thank you, Mr. Chairman. My name is Daniel Waite. I am Deputy Secretary for Operations at the Department of Human Services. In calendar year 23, the 23 legislative session, HB 982 was passed by this body. Part of that legislation called upon the department to set up an internship program and a hiring program with certain eligible high school or school systems, those being Baltimore City, Baltimore County, and Prince George's County. Mm-hmm. In addition to that, we were called upon to set up a scholarship program for people who are interested in human services careers, yep. Also focusing initially on those jurisdictions, but then expanding that out to potentially our current employees and to other folks who are enrolled in eligible school or higher education institutions. So our focus, because of the budgeting of the scholarships, was to get the scholarship program rolled out and then focus on the internship program in the spring of 24. So we have not yet had a cohort of folks go through that internship program in order to give those stipends, but we intend, as we roll out that internship program, to make sure that it is accessible in those jurisdictions that qualify, and that we are being equitable and diverse in the way that we give access to those internship programs.
Well, thank you. I'll rephrase that question. When you all do start to move forward with the program and you have some preliminary numbers, can you please share with the respective committee?
Absolutely.
The second and last question, Mr. Secretary, just deals with the 13 positions that have been vacant for over 1 year. If you guys can just get back with Ms. Andrade in reference to the classifications, and like if there are some formal plans about those, but just the 13 positions.
Absolutely. Happy to do so.
Yes, sir. Colleagues, seeing no further questions, Mr. Lopez, your Secretary Lopez, you are here all the time. We said enough, but thank you for the work that you're doing. In reference to
team effort.
It's a team effort. Great way to put it. And Ms. Andrade, just thank you again for continuing to make sure that you move us in the right direction and knowledgeable about what the respective agencies are doing. Thank you. Colleagues, this ends the hearings for Health and Human Services. Look forward to seeing you